So once again, these are going to be some cases I'm just going to kind of go over with you guys, just kind of review them and sort of approach these in a way that I would look at it. So here we've got a shave biopsy. It's a neoplastic process that you can see at low magnification, and it looks really small. I mean, the entire biopsy can go down here on the slide. It's only probably about a millimeter or two, and it's got a dermal-based process here. And it's obviously strongly favor benign when you look at something like this. It's very, very small. It's well circumscribed. It's got all those features that we've talked about many times before. On this side, you see another area of the same lesion over here. And low power, it's kind of hard to say whether it's epithelial or non-epithelial. It's got this interesting little finding here, which we see a lot of times in things like nevi. Sometimes you just do shave biopsies or punch biopsies, maybe for an inflammatory process, and you'll see what looks like fat way up high in the lesion. And it's been a puzzle to dermatopathologists for many years as to why that happens and even what it is. It's been referred to as fatty metaplasia, where you get lipocytes that form in areas that are not really where the fat should be. And we see that sometimes as maybe in the upper reticular dermis, usually not so much in the papillary dermis. But here we've got it sitting in the middle of a neoplasm, which is interesting. So don't let that fool you. That's not, a lipoma or anything like that. And, sometimes the board likes to put a kind of a red herring answer on there to try to throw people off because something that may be unusual in the slide. And so don't fall for that. That's just what we call fatty metaplasia. That doesn't really mean much of anything. So at this power, you can begin to make out that there's some epithelial structures here. They're little small ducts. And the stroma has also got this pallor, kind of a bluish gray color to it. So we all know that whenever we see bluish gray in the skin, we start thinking of things like mucin, lipid, extracellular lipid, like an eruptive xanthoma can look bluish gray. And so go to higher magnification, and now we see these are nice little beautiful ducts here with these cuboidal cells, with these nice little round nuclei. Some of the cells have got some clear staining cytoplasm, others have almost no cytoplasm at all. So that really looks very much like an eccrine sweat duct or possibly part of the eccrine sweat gland. And as you know, the clear staining cells are the ones that contain the glycogen. They're the metabolically active cells. And so we've got mucin, we've got ductal differentiation, we've got a small lesion that's very well circumscribed, totally benign in its appearance. It's a nice example of a mixed tumor of the skin, also known as a chondroid syringoma. Now, why do we call it a chondroid syringoma? Well, if you just look at a regular syringoma, they contain these little small ductal elements like we see here. And then the mucin in the stroma can undergo cartilaginous metaplasia. So we have fatty metaplasia, and then we can get cartilaginous metaplasia. In this case, we don't have any cartilaginous metaplasia, so probably would be better to call this maybe a mixed tumor rather than a chondroid syringoma. But those are really both analogous synonyms, if you will. So benign lesion, eccrine differentiation, and it's got this nice example of what we would call a mixed tumor, with the mixed component being the mucinous stromal component and then the epithelial component. That's why it's called a mixed tumor. The only couple other teaching points about this is that if this obviously didn't occur on mucous membrane site. We're looking at sun-damaged skin, so it's not in somebody's mouth or anything like that. But if you get the same exact lesion and it's in the mucous membrane, usually the mouth, most commonly, it's basically called a pleomorphic adenoma, and that's the same exact morphology basically that's occurring in association or as a sort of differentiating toward the minor salivary gland. And so in the oral cavity, it's known as a pleomorphic adenoma. We still could call it a mixed tumor, but if it occurs in the glabrous skin, we call it a mixed tumor or chondroid syringoma. Those lesions, these almost never become malignant. They can rarely, but almost never. The ones in the oral cavity more commonly can become malignant. So again, we usually, if we were to see something like that, we might recommend removal, because if you leave it for a long time, they can gradually undergo malignant degeneration. And the only other final thing is if you stain the pleomorphic adenoma with a smooth muscle actin stain, it will highlight that. This lesion, not so much, but the lesions in the minor salivary gland area, the pleomorphic adenomas, they will highlight with myoepithelial cells that surround the glandular elements in that area. So that's a mixed tumor of the skin. Okay. Another biopsy, again, excisional biopsy this time, and this lesion, as opposed to the last one, is much, much larger. It takes up almost the entire width of the slide. So you all know how thick a slide is, and so this is a fairly big lesion, and it's a large nodular aggregation. Okay, and at low magnification, you can see that it's got this blue color to it. So when we think of something looks bluish or almost black at low magnification, you start thinking of lymphoid cells possibly, but also other cells that can give you blue color in the dermis. And the differential diagnosis of that is not gargantuan. It's not super long. Things like neuroendocrine differentiation, and then the different sort of subtypes of things that can give you neuroendocrine differentiation, things like small cell carcinoma that metastasizes to the skin, primary Merkel cell carcinoma, for example, carcinoid syndrome, lesions of the apid system that can involve the skin secondarily. Those are all in that category. Wilms tumor, neuroblastoma, if this were a child, something like that. So you sort of think about those lesions when you look at it sort of at low magnification. And so you ask yourself, well, is this benign or malignant? Well, it's pretty big. So right off the bat, you say, well, that sort of favors malignant. It doesn't have to be, but it tends to favor it as opposed to the last, which was very, very small. If you draw a line down the middle of it, it's not really very symmetrical. I mean, you got this large aggregation that over here, these cells have coalesced, and you got the smaller areas over here, these small little nodular aggregations. So this doesn't really look exactly the same one side or another. But then you say, well, what about circumscription? Well, it's not too poorly circumscribed. You can kind of draw a line around the whole thing. So we know that if it's perhaps a metastasis, it can kind of break the rules a little bit of whether it's well circumscribed or not. If you get a cannonball metastasis, say from a melanoma or from a carcinoma, breast cancer, or maybe a lung cancer, those can sometimes look well circumscribed. It can be relatively small sometimes. So they kind of break the rule of the pattern analysis, low magnification. And this doesn't involve the epidermis. So it theoretically could be a metastatic lesion. And so we go to higher magnification. It doesn't look like the cells are jet black. So again, I'm thinking it's probably not going to be a lymphoma, even though there are variants of lymphomas, large cell anaplastic lymphomas, for example, those large B-cell lymphomas, poorly differentiated B-cell lymphomas of the leg. Those cells can be so large that they don't look black anymore. They can kind of look more purplish. So again, it theoretically could still be that. But as you get to sort of higher magnification, it really doesn't look very much. These are not really lymphocytes. You can see that these cells they're degenerating. They've got this sort of irregular smudged chromatin pattern. Here you got some inflammatory infiltrate inside the lesion, and some of these small cells actually may be part of the neoplastic process itself, interestingly enough. And then over here, you see some of the cells arranged these little sort of cords and strands here. And notice this sort of indistinct chromatin, smudgy pattern. That's pretty characteristic of neuroendocrine differentiation when we see this. And so if we were to see something like this, we would be quite concerned about Merkel cell carcinoma, maybe a metastatic small cell carcinoma. These probably are lymphocytes. So if you look at the difference between the lymphocytes here and these larger cells with a much more cytoplasm and this irregular chromatin pattern versus the lymphocytes, you can see they look quite different. So even if this was a malignant lymphoma, the cells really look pretty different than a lymphoid cell in most of these areas. So this would be in that general category of differential diagnosis. Now, you're not going to be asked to just look at something like this and say, this is small cell carcinoma of the lung versus, primary Merkel cell versus a metastatic Merkel cell, which it still could be. You might be asked to just get it into the category of neuroendocrine differentiation. And they might ask you some things like what kind of markers you might use to work this up more thoroughly. And so the classic markers that we use in our laboratory is we use cytokeratin, which especially, and cytokeratin 20, which is usually positive. It can be negative in some cases. And if it is positive, it gives you this classic paranuclear dot pattern. And if you look very carefully at some of these cells, it's really hard to see here, but it's got this little tiny sort of pink dot right there. And maybe we kind of scroll around, we might see a few more cells that might have some of those little dots right there. Those are the little small dots of cytokeratin that you will highlight when you do the cytokeratin or the cytokeratin 20 stain. So when you actually look at that stain, you'll see this nice, beautiful little dot, and it kind of correlates to those little small pinkish aggregations that you can barely see with routine H&E staining. So that's, if it's positive, and it is positive most of the time, that's very helpful. The other thing to do is some immuno stains directed to neuroendocrine differentiation. And there's about 4 or 5 of those. INSM1, which is insulinoma marker, which is actually, from the cells in the pancreas. They directed immunoproximity stain to those cells. Those will obviously highlight neuroendocrine cells because it's basically the same differentiation. Synaptophysin is another one that's pretty good for neuroendocrine differentiation. And then there's a couple others, chromogranin, and those are the main ones that we really look for. Now, the other thing that you might get a question about is that it's more common to get thyroid transcription factor 1 staining in a metastatic lesion, like a metastatic small cell carcinoma from the lung to the skin, versus a primary Merkel cell carcinoma. It's not 100% true, but and a lot of times we'll see like a metastatic small cell carcinoma that's TTF1 negative. But the rule is, if it's TTF1 positive, it tends to favor a metastasis. And, this could be a met. I mean, it doesn't have any involvement in the epidermis. We can't say it's not maybe a recurrent Merkel cell, that maybe they had one here near the site and it recurred locally at the area because it underwent a satellite metastasis. But it still could possibly be a primary Merkel cell carcinoma. So we're not really sure about that. All we can get into the category of malignant neuroendocrine neoplasm here. Now, the only other thing I would say is that sometimes we don't really, well, 2 other things, I guess. Number one, remember that this lesion is associated with polyomavirus infection in some cases. So you want to make sure that you remember that. And then the last thing is that sometimes you'll see overlying squamous cell carcinoma associated with the Merkel cell, with even invasive areas of squamous cell carcinoma adjacent to the Merkel cell. So we see that sometimes also. Usually that pattern is seen in the types of Merkel cells that are associated more with sun damage. However, that's not a hard and fast rule, but that's a general rule. But just realize that you can sometimes see that. And you can see squamous cell carcinoma in situ overlying Merkel cell carcinoma. Don't see it in this case. So this might even be a metastatic lesion, like I mentioned before. But those are just a couple of the pearls to remember when you're dealing with this entity. Okay, the next case, 3, right side up. All right, we've got another shaved biopsy. And again, at low power, this doesn't look like an inflammatory process. Something is going on here where there's some unusual cells in the dermis. We're not sure what they are at this power, but there's definitely something here, and it looks like it's neoplastic. Is it benign or malignant? Well, sort of like the first case, it's pretty small. So we might say, well, maybe it's going to be benign. And what about symmetry? Well, you look at it and it's not perfectly symmetrical, but, it's not just screaming highly asymmetrical lesion. So, we say, maybe it's going to be benign. It's got 2 features that are benign, and then it's actually not very poorly circumscribed. So it's kind of got at low power, would favor benign when you just kind of first look at it, low magnification. What kind of cells are these? Well, they certainly look like they're non-epithelial. They're clear staining, pale cells in the dermis. So we're not sure exactly what kind of cells they are, but it certainly doesn't look like a spindle cell neoplasm, like something like a neural lesion, for example, or a fibrohistocytic lesion. So there's something epithelial, perhaps here with clear staining cells, or maybe it's melanocytic with clear cells, like a patch, like a balloon cell, melanoma balloon cell nevus, that sort of thing. Let's go to higher magnification, and now we start noticing that there's a lot of erythrocytes in here, a lot of blood in this lesion, a lot of vascularity to it. So that's an interesting clue. Could it be a vascular neoplasm itself? And, there are some examples of epithelioid angiosarcomas where the cells can be clear, but would be a little bit unusual to get these nodular aggregations in the lesion. And now if you start looking at this, you see that there are these nodular aggregations, like I said before, comprising this. So it's multiple little nodular aggregations together, forming one large little aggregation here, or one little papule. And as we go to highest magnification, we now see that these cells have got this markedly clear staining cytoplasm with these round nuclei. They don't really have the gossamer sort of starry appearance that we see, like, for example, in a sebocyte. They've got this round nucleus, but they do have these little small strands of material, which is probably going to be nucleoplasm and maybe some cytoplasm here within the cells. And then you've got this very large blood vessel here. We've got a lot of extravasated erythrocytes over here, a lot of blood cells here. We might even have some vascular spaces in which there may be some neoplastic cells. Okay. And we just talked in the last case about the possibility of metastatic lesions. So here, these cells don't look like they're normally present in the skin. They don't look like, we mentioned balloon cell nevus, for example. Well, these don't look like nevus cells at all. They don't look like cells of sebaceous cells, which can be clear staining. They don't look like histiocytes that have a bunch of lipid in their cytoplasm, and all this red blood cells here. And if you look at this little structure here, it's almost recapitulating a nephron in the kidney, like a collecting tubule, if you will, right in this area. So this is an example of a metastatic renal cell carcinoma, and it's one of the entities in the differential diagnosis of clear staining neoplasms in the skin. And as you know, these lesions often occur on the head and neck area when they metastasize. They're often very, very bloody. And in fact, in some cases, these things can even pulsate. They can be so vascular and have so much and there's so many erythrocytes within them, it looks really, really red. And when you do a shave biopsy of these things, they bleed a lot. So this is a nice example of this entity. And it's something that would be theoretically fair game on the board examination because it's got that characteristic clear staining cytoplasm, multiple aggregations with a lot of blood vessels and extravasated erythrocytes. So they might show you this. If they did, they probably just wouldn't throw it up there and say the best diagnosis is blank. They might give you a clinical photo and show you this and then expect you to correlate it. But it is pretty characteristic of a metastatic renal cell carcinoma. And it is interesting because it is small, compared to the Merkel cell that we saw a minute ago. This is a much smaller lesion. And a lot of times you look at individuals that have this when they do metastasize to the scalp, the lesions can be relatively small. They don't have to be giant, huge nodular aggregations when they occur and metastasize. They can be little small lesions about the size of a BB, for example. So something to remember. The other thing that's interesting about this lesion, it's associated with the Birt-Hogg-Dubé syndrome. So again, if they were to show you this and say what syndrome is associated with this metastatic entity, you need to know that Birt-Hogg-Dubé is associated with renal cell carcinoma. A lot of patients that get this, there's actually two types of renal cell carcinoma. There's the papillary type, and then there's another type that can be more aggressive. And so they're not going to ask you that. But interestingly enough, a lot of people that have Birt-Hogg-Dubé and get metastatic renal cell carcinoma, they don't really behave as aggressively as the other form of renal cell carcinoma. They can live for many years, even though they get a metastatic process. So renal cell carcinoma, like thyroid carcinoma, like certain lymphomas or whatever, it's not always a death sentence when they get this. And patients can live often for many, many years with renal cell carcinoma, even if it's metastatic in some cases. And as a general rule, and I'll give credit to Jared Gardner for this, if a lesion is a cancer from a genetic mutation, not a somatic mutation, but a germline mutation, they tend to behave better than sporadic cancers that develop later in life that are from a somatic mutation from some exogenous insult, like, from the sun or something like that, for example. So as a general rule, if you're going to get a cancer that's germline mutation, they tend to do better than cancers that develop from non-germline mutations. Not always, but that's the general rule to kind of remember. Okay. Another biopsy, and today, as opposed to, I think maybe the last time we did this session, we had a lot of inflammatory things. We've got a fair number of neoplastic things this morning. So we've got a punch biopsy. So again, you say, well, punch biopsy, maybe inflammatory, but if we look at low magnification, it's got some little dark cells here, but certainly doesn't look like they're lymphocytes. We notice there are some little clear staining areas up in this area, little holes throughout the lesion. So we see things at low magnification like this. We say, well, there's blood vessels in here, most likely. It's vascular, at least to some degree. But, this still at this power could be an inflammatory process. It might be a superficial perivascular dermatitis, for example. So we're not really sure at this power what we're dealing with. So we're going to go to higher magnification. And as we go to higher magnification, we start to see that there's a lot of blood vessels here, way too many, far too many per unit area. This is not a normal amount of vascularity in someone's skin. So we say, well, it's vascular, so it's either a vascular proliferation, like maybe a pyogenic granuloma, or maybe severe stasis dermatitis with acroangiodermatitis, for example, or maybe it's a vascular neoplasm. And if it's a vascular neoplasm, then we have to ask ourselves, obviously, if it's benign or malignant. And so can we apply our criteria? Well, we can assess the breadth, the symmetry, the circumscription very well because we've got a punch biopsy out of probably something that was larger. We can look at and to see, well, based on this biopsy, is it symmetrical, well circumscribed to what we have? Well, the answer is no. It goes to both edges of the specimen and to the base, so it's certainly not well circumscribed. Is it symmetrical? Well, not really either. This is a piece of something bigger, but it's much more cellular and more dense over here than it is over here. So those are yellow flags to us. We're a little bit concerned when we see something like that. And then obviously, if we're dealing with a vascular process, benign is hemangioma, and there's a whole family of hemangiomas. And then of course, angiosarcoma is the malignant counterpart of that. And then there's also Kaposi's sarcoma, which is a sort of, in a way, it's like an angiosarcoma, but it's not exactly an angiosarcoma that starts off with one lesion and can spread. It's a widespread multifocal process that we know is due to HHV8 infection. So is this an angiosarcoma? Well, then we're going to go to higher magnification and look at the cytology. And now we get really concerned because these cells are very large, they're plump, they're hyperchromatic. They have atypical endothelial cells that are present in the lumen of a number of these vascular spaces. So now we get very concerned that we're dealing with an angiosarcoma. It's also got these other vessels that are really, really bizarre and have this so-called staghorn appearance, staghorn or deer horn or elk horn, whatever you want to call it. That's more characteristically seen in an angiosarcoma than in a typical small hemangioma. And then the endothelial cells that are large, they're coalescent. There's some of these cells are quite pleomorphic and they're really hyperchromatic. Those are all features of an angiosarcoma. And so here's another example of one of those staghorn irregular blood vessels here. Now, on a scale of 1 to 10, this is probably maybe about a 3 with regard to differentiation. It's not a poorly differentiated lesion. This is fairly well differentiated. We can look at this and say, yes, this is a vascular lesion, and it's an angiosarcoma, and it looks relatively well differentiated. Sometimes you look at these angiosarcomas and they're super atypical with a lot more mitoses, a lot more striking atypicality and pleomorphism that we see here. And one of the situations, this was actually a fairly reasonable biopsy. They took a good deep punch biopsy here. It's about probably a 6 millimeter punch, which is good. But if you were to get a shave biopsy of something like this, and this is all you saw just right here, you couldn't make the diagnosis of an angiosarcoma, even if you had maybe the shave kind of encompassed a couple of these blood vessels. And so this is a situation where you really need to make sure that you take a good deep biopsy like this, either an incisional biopsy, a deep saucerization biopsy, or a deep punch biopsy, and send it in with perhaps clinical pictures. Don't just send something like this in as neoplasm uncertain behavior with a shave biopsy, and because you're likely to get back a diagnosis of a hemangioma, or maybe even telangiectasia, something like that. And that's not what you want. And that's going to lead to all sorts of problems. A delay in diagnosis of this, the problem is usually patients have this for many years by the time it's diagnosed, but it's a malignant neoplasm, and you don't want to leave it in situ without getting a diagnosis. You want to get this diagnosed as quickly as possible. And I've seen many, many cases over the years of misdiagnosis of angiosarcoma for several different reasons. And probably the number one reason is failure to do clinical pathologic correlation and take a good biopsy. I've seen these lesions misdiagnosed as melanoma. I've seen them misdiagnosed as squamous cell carcinomas. I've obviously seen them misdiagnosed as benign angiomas and telangiectasia and that sort of thing when you get an inadequate biopsy. So you really need to make sure that you kind of provide the dermatopathologist with good information on this. I would recommend probably sending a clinical photograph in with something like this. And these often present on the head and neck area of older individuals, and they kind of look like a bruise on the scalp or the face. That's one setting. Also, that's been a name associated with that is Winchester's syndrome. And then you also can get the Stewart-Treves lymphedema associated angiosarcoma, and especially seen following breast surgery. We don't see it as much today. We're doing lumpectomies, but in the old days, they did radical mastectomies. Patients would get really bad lymphedema, and then they would get a secondary angiosarcoma. And you also get angiosarcomas in patients that get lymphedema of the leg and other locations too, so it's not confined to the upper extremities. But this is an example of that. And then you can also get angiosarcomas with different histologic morphology. Sometimes the cells can be very large and they can look like a carcinoma, for example, a so-called epithelioid angiosarcoma. So in those cases, you want to make sure that you work it up with appropriate staining to prove that it is a vascular lesion as opposed to an epithelial lesion, because the prognosis is way worse for this than it is for a squamous cell carcinoma. So that's pretty much most everything about angiosarcoma. And you could get I would say this is probably going to appear on your board examination somewhere. They might show you the clinical photograph, might show you clinical plus the histology, but you probably will face angiosarcoma somewhere on the examination. Okay. Shifting gears here. We've now got a shave biopsy, and this looks like it's from volar skin. And at low magnification, it looks pretty unimpressive. Unfortunately, the biopsy is pretty superficial, but they probably were not thinking about, they're probably thinking about a neoplastic process would be my bet. And you can see the epidermis is a little bit acanthotic, but that's actually maybe not out of the realm of normal for this location. The stratum corneum is pretty thick. It's also probably within the range of normal for this location. So we're probably shaving this to rule out some kind of a neoplastic process on volar skin. Maybe they thought it was wart. Maybe they thought it was something else. Let's go to higher magnification, see if we can see anything else that really strikes our fancy. And again, notice there's virtually no inflammation. There's virtually nothing at the dermal junction. So they probably, if they were thinking about any kind of melanocytic lesion, it would be very subtle. It might be like a simple intigo or some kind of epidermal hyperpigmentation, or maybe some kind of a tattoo in the cornified layer, all those various things. And so this would be something, again, on the board examination, you probably would get some clinical information if they were to show you something like this, because it shows basically almost nothing here. So when you see a nothing lesion, you start thinking of your differential diagnosis includes a number of different entities that you see when you don't see anything at the low magnification. So maybe this is some kind of maybe it's urticaria, which would be very, very subtle and show very little inflammation. Maybe it's a pigmentary disorder. Maybe it's vitiligo. Maybe it's a hypopigmented process like progressive, macular hypermelanosis. Maybe it's something in the cornified layer. Maybe it's some kind of a disorder of keratinization, which can give you no inflammation. Let's look at a little higher magnification and see if we see anything else. And as we look, we start seeing there's something dark in the cornified layer. So there is some kind of pigmentary abnormality here. Is this a tattoo pigment? So some patients get exposed to silver nitrate and they get a black discoloration in the upper part of the stratum corneum here. Well, this doesn't really look like that. That's usually like a diffuse homogeneous black discoloration that goes over the whole thing, and you start seeing these small particulate granules, which is the silver nitrate that's been applied to the skin. But we start seeing that there are these small little tube-like structures in the cornified layer, and these happen to be hyphal elements. And here you see some that are almost growing at right angles here to the stratum corneum. And so this is an example of Tinea Nigra. And of course, they did a shave biopsy of it. because it's presented as a macular pigmented lesion on volar skin, and they naturally were concerned about acral lentiginous melanoma when they took this shave biopsy, or maybe they thought it was an acral nevus or something. And so when you go look at the clinical photos of this, it usually doesn't look that much like a melanoma. It's usually kind of a nice round circumscribed area, and it's usually tan as opposed to being black. So it doesn't usually look that much like a melanoma, but it is a pigmented lesion on acral skin. So naturally people get concerned about it. They take a shave biopsy. Sometimes they might even give you an incisional biopsy, and it just shows no evidence of anything going on down there in the epidermis. So you always have to look in the cornified layer, and you see this, so you should know that this is a pitfall that clinicians make when they see pigmented lesions, that it really can be Tinea Nigra. So it's always a good idea to kind of understand where clinicians can make mistakes when they take biopsies. This is one way. We have seen things like silver nitrate tattoos or carbon tattoos. They think those are melanoma in the mouth, and sometimes now not only in the mouth, but in glabrous skin, where patients may have had either traumatic implantation of silver, either from a tattoo, amalgam tattoo in the mucous membrane. Those are often thought to be melanomas. And then, of course, we get secondary argyria from piercings. Those can give you bluish black discoloration of the skin. Those are thought to be melanomas. So it's a good idea to just kind of know in general clinical miscues. Dr. Ackerman actually wrote a text on that years ago, knowing that things that the clinicians can think of and say, now I know why they thought that, because it can look like this. And you have to know clinical dermatology to really be able to know what those clinical miscues are. So it's important to know where you're going to make a mistake. And this is a classic one where the clinicians think it's a melanoma, and it turns out to be this. Hemorrhage in the cornified layer is another classic example where it's thought to be melanoma and it's not. And that actually is a situation, and when you're dealing with nail unit pigmented lesions, that is often just secondary to trauma. It's not really a pigmented lesion at all. Okay, this is a beautiful example here. And once again, if you're going to get on the slide part of the exam, at least, if you're going to get an inflammatory skin disease, this is the kind of specimen you're going to get. You're not going to get an inadequate biopsy. You're going to get something that's a nice, deep punch like this, or an incisional biopsy. And so that's kind of important. If you've been studying dermpath and you've been looking at things that you just get submitted to a general lab, a lot of those are not going to have these beautiful examples that we're looking at right here. So make sure you look at your textbook and see some good examples also. You may be looking at a lot of unknown slides that are shave biopsies of melanomas, for example, and just to kind of see a lot of stuff, which is good, and you want to do that. But make sure you're also looking at some classic examples too. I remember when I took my board examination, they had a biopsy of Capsucene-sarcoma, but it was a huge, giant excisional biopsy of Capsucene-sarcoma. So I'd never seen an excisional biopsy of KS before. But the reason they used that was back in the day when I took it, we actually had glass slides, and you had to get, I think, 80 sections or 40 sections of the lesion. And so when they would ask a dermatopathology laboratory to provide them material for the exam, you had to have a specimen large enough to get 40 cuts out of it. So you couldn't get 40 cuts out of a shave biopsy of something. You had to get an excisional biopsy. So sometimes you get these large biopsies of things that really you never saw. You almost always get small biopsies. So it can sometimes throw you off when you're looking at it and say, well, I'm not used to seeing an excisional biopsy of KS. It was kind of curious. So you have to make sure that you're used to looking at something like this. So we've got a punch biopsy here. And it's obviously at low magnification. It looks like an inflammatory process. We've got dark staining cells here, which will be lymphocytes. And we see the top part of the specimen is spare. We don't see any involvement in the epidermis at low power. I see no epidermal, no dermis involvement until we get down here. But we see involvement in the subcutaneous fat. So we're dealing with a paniculitis at low magnification. So that's the good news, is you can quickly get into the category of paniculitis. And paniculitis is one of those entities where it's very formulaic. We have a very systematic approach. We ask ourselves, is it lobular versus septal? And we say septal mostly versus lobular mostly, because there's always a little overlap between the two. Sometimes something can be purely septal, but if the septa is inflamed, Septum's inflamed. Usually there's some sort of periseptal inflammation too. So we say mostly septal or mostly lobular. And this power, we can see that the lobules are almost totally involved here. So it's involving mostly the lobules. The septa are probably secondarily involved, but it's a mostly lobular paniculitis. The second question we ask ourselves is there vasculitis or not? Because we know that there are diseases that classically give you vasculitis in the subcutaneous fat. Arteritis nodosa, for example, gives you a septal, mostly paniculitis with vasculitis. Nodular vasculitis is a lobular, mostly paniculitis with vasculitis. So vasculitis is an integral part of looking at paniculitis. And at this power, we really don't see any vasculitis involvement. We just see diffuse involvement of the subcutaneous fat. So we're seeing a lobular paniculitis without vasculitis. The next step is to ask, are there any other factors involved that can help us lead us to a more precise diagnosis? What kind of cells are involved, for example? Well, at low power, these are going to be dark black cells, so they're going to be lymphocytes, as well as we're going to see probably maybe some other cells here too, because they're not just jet black. So they're mostly lymphocytes, but there may be some other cells in here as well. And we also see that there's some fat degeneration at low magnification. So we're going to say, well, what kind of fat degeneration is that? Is it got this classic saponification that we see with pancreatic paniculitis, for example? And we don't see that. We see basically diffuse involvement of the lobules here with this pink hyaline degeneration of the fat and replacement of that fat with fibrous tissue. It's becoming fibrotic and sclerotic. Collagen is replacing that. So here we get this degenerated fat. We've got this pink mummification of the fat. We've got lymphocytes in here, and also we've got some plasma cells in here. There were lots and lots of plasma cells, and actually, surprisingly, a few eosinophils here, which is relatively uncommon, but something that you can see in this entity on occasion. So, again, the textbooks talk about these things as being a lobular, mostly paniculitis, lymphocytes and plasma cells in this mummification. Classic presentation of lupus erythematosus profundus or lupus paniculitis. But you can, and the textbooks will not state that there are eosinophils in here, but here we go. We actually see some EOs in this specimen. So you can see eosinophils, or actually you can see eosinophils in other forms of lupus erythematosus as well, discoid LE, acute LE. It's relatively uncommon, but it is present on occasion. So just don't let that throw you off. Don't let some minor feature distract you when everything else is present. Apply the criteria like we just did, go through it like that. And then if you see a couple of EOs and then they put down their eosinophilic fasciitis as a choice, don't let that throw you off because it's got everything else here that's classic for lupus erythematosus profundus. So nice, beautiful example of that. And one thing about LE profundus that's interesting is most of the time, about 60% of the time, you'll see some overlying evidence of LE. We don't really see much of that here. A little bit of a lymphocytic infiltrate, maybe a little bit of mucin, but no interface change. But I'd say more often than not, you'll see some examples of overlying sort of discoid LE-like changes or subacute LE-like changes in the overlying epidermis of the dermis. But we aren't seeing that in this case. And about 60% of these patients will also have evidence of systemic LE serologically. So if you get someone with LE profundus, it's not just purely a paniculitis. They're almost certainly going to have other manifestations of lupus elsewhere. They may have kidney involvement, they may have lung involvement, they may have lupus vasculitis somewhere else. So you need to make sure that you work the patient up and exclude any underlying systemic manifestations if they have this. This is the most common paniculitis of the upper part of the body, of the arms, the trunk. It's often seen in younger individuals. So, and often in women as well, as you can imagine. So nice example of a beautiful example of lupus erythematosus profundus. Okay. Another example here of a punch biopsy. And we'll take a look at maybe these two pieces over here. This one's actually got a nice clue to it. And inflammatory neoplastic, well, there's something going on down in this area here. And we see these nodular aggregations of these pale staining cells. So it's theoretically possible it could be a neoplasm, but say, well, maybe it's an inflammatory process with these nodular aggregations of histiocytes in the dermis. So it's more likely to be an inflammatory process when it's got these nodular aggregation of histiocytes like this. We think it might be a granulomatous inflammatory process. We know that there are 5 major patterns of granulomatous inflammation. There's suppurative granulomatous, usually seen with an infectious process. There's foreign body, there's tuberculoid, there's sarcoidal, and then there's palisaded. And so at this power, we would say that this, if it's granulomatous, it's going to be sarcoidal, round epithelioid granulomas. And sarcoidal, here we don't really see too much in the way of a lymphocytic infiltrate associated with it. So we say, well, maybe this is going to be sarcoidosis itself. Maybe it is. But there's something else here. There's 2 things I want you to see in this focus here. Number one, there's this black material, foreign material. This doesn't belong here. It's black. And then notice, do you see these little lines here? They're linear lines. Those are created by man. These are artifactual tears where the microtome blade is passed through the tissue and it's taken this black material and ripped it right through. And this is a sign, it's an artifact, but it's a sign of foreign material that's present in the skin that's really in the plane of the tissue. So this material is hard enough that a microtome razor blade tore it through the skin like this. So that's a clue that you're dealing with a foreign material when you see this. So it's a helpful clue. Remember that. So if the differential diagnosis here is sarcoid versus sarcoidal reaction to a foreign body, even if you didn't see this black material, maybe it was clear, maybe it was silica like glass, which is very common. We see that even more common than this blackish material here. You would say that it's more likely to be a foreign body than just sarcoid itself. And if you look into these areas here, you can see that there's this blackish material inside some of these histiocytes up here. And we don't really know exactly what this stuff is. It could be tattoo pigment. It could be something that was introduced by trauma. So patients that get into car wrecks and they get soil in their skin, you see all sorts of material that can look blackish sometimes like this. This looks a lot like carbon. So you kind of wonder if this person maybe had a non-professional tattoo. Maybe there was a prison tattoo or a gang tattoo or something like that, and they put the carbon in, and it wasn't pure ink like we see with that supposedly the tattoos from a tattoo parlor, for example, are going to have, and maybe they got a secondary granulomatous reaction to this. Now, one other important pearl about this, even though it is a sarcoidal granulomatous reaction to tattoo or to carbon or some exogenous material here, these things can actually precipitate real live sarcoidosis in patients. Okay, so patients that undergo microblading, where they actually tattoo this vegetable type dye into the skin. We've seen this happen a number of times here, and there's several articles written about this in the literature. Often seen in African American patients, especially women that get the microblading of their eyebrows or their lips, for example. They can develop this granulomatous reaction to the tattoo pigment, and then they get hyaline-lymphadenopathy, or they may get lacrimal gland enlargement. So they get really true sarcoidosis that gets precipitated by the tattoo. So, if you're in an ethnic, group that's got a risk factor for sarcoidosis and maybe a family history or whatever, and you don't have it, or your patient doesn't have it, and they're asking, well, should I go get my eyebrows microbladed? I would probably recommend against that, because this stuff can actually precipitate real sarcoidosis in certain settings. So that's something to just remember, that it can actually cause true sarcoidosis in the right situation. It's not confined to African-American patients either, by the way. You can get that in non-African-American patients too, but it just seems to be a little bit more common in that setting. So beautiful example of a sarcoidal granulomatous reaction to foreign material, probably a tattoo pigment in that situation. Okay. Another punch biopsy, and got 2 pieces of the tissue, but I think it may actually give you a little better view on this side over here. So in low power, Looks like an inflammatory process. We don't see any neoplastic cells here, nothing that look like the metastatic renal cell or the Merkel cell carcinoma we saw earlier. We've got an inflammatory process that's mainly superficial perivascular dermatitis here, maybe superficial in mid, goes down to the mid-reticular dermis, but not deep. And these cells at low magnification, I hope you can appreciate from comparing this with the case of the lupus profundus, are not going to be all lymphocytes here. They're small, but they're not jet black. Okay, so they're going to be some other kind of cell here, maybe neutrophils. There may be some lymphocytes here, but there's going to be some other cells in here almost for sure when we go to higher magnification. And what's the pattern? Well, superficial perivascular and mid, mostly superficial, but notice how it's also hugging the epidermis here. So there's an interface component to this process, interface dermatitis. And we know there's two main types of interface dermatitis. There's lichenoid, and then there's vacuolar, and sometimes there can be a little bit of both, but we know that there's going to be interface dermatitis here as we go to higher magnification. So we're going to look at the epidermis to see if there are any other factors that help us with this. So if we think it's maybe a lichenoid dermatitis, for example, we're going to see if there's going to be wedge-shaped hypergranulosis and sawtooth epidermal rete for lichen planus, for example. If we see plasma cells, perhaps, and maybe some poorly formed granulomas, we might think of secondary syphilis, which can give you this pattern. We're going to go to higher magnification yet again. It's that while some of these cells are lymphocytes, a number of them are also neutrophils here, neutrophils. And we've also now got some other features in the epidermis that help us. We've got lots of vacuolar alteration here. So we talked about vacuolar as being one of the types of interface, and it's got maybe a little lichenoid inflammation, but it's mostly vacuolar. We've got these pink structures in the epidermis, which are necrotic keratinocytes. They're dyskeratotic keratinocytes. We've got these broad zones of parakeratosis that contain neutrophils within them. So it's kind of almost like a broad wafer-like parakeratosis. And then we've got extravasated erythrocytes here. Now, this is an interesting lesion because if I were going to ask you how long you think this lesion had been present, I would hope you would say maybe just only a day or two. It's probably a fairly acute lesion because it wasn't really scaly yet. And why was it not scaly clinically? Because it's still got the basket weave cornified layer on it. This is going away. If we biopsy this in a couple of days, this is gone. And it's just dealing only with this at the top. So this is being sloughed off. It's being replaced by this. This epidermis is dying. It's got these necrotic keratinocytes, and it's actually got this abnormal cornified layer on it. This is a classic example of Pityriasis lichenoides. And it's probably it is an acute lesion. Now, the classic form of mucohydral disease is a very dense, superficial, and deep wedge-shaped infiltrate, deeper infiltrate than we see here. But this is probably a fairly early stage lesion that might eventually get a deeper inflammatory infiltrate, but it is in the family of the Pityriasis lichenoides diseases. And it's probably not Pityriasis lichenoides chronica. In that condition, you don't get as many dyskeratotic keratinocytes, you don't get as many extravasated erythrocytes. But patients that have Pityriasis lichenoides chronica, they can have it for 10 years, 15 years, can get acute lesions and acute episodes that develop within that process over the course of the disease. So diseases that have the word chronica in them, like chronic discoid lupus erythematosus, for example, patients can develop acute lesions periodically, even though they might have the disease for 10, 15, 20 years. So not really a good using chronology to sort of define a disease is a little bit flawed in that way because patients can develop exacerbations and remissions and have acute lesions even though they may have the disease for a long period of time. So this is a fairly acute lesion, and I don't know how long this person's had this disease. This might be the first outbreak of it. They might have had it for a long time. It looks like it's probably not an old individual. They don't have any sun damage here. And we do know this disease does occur most commonly in children or in young individuals. So a beautiful example of Pityriasis lichenoides that probably a fairly early lesion since it still has the basket with cornified layer on it. Not too much other teaching points on this. There are lymphomatoid papulosis can sometimes look similar. Usually that's going to give you more epidermal necrosis and you get the atypical lymphoid cells here. We don't really see any of that in this condition. So pretty straightforward example of Pityriasis lichenoides. Okay. Another deep biopsy here, possibly a punch, maybe an incisional biopsy. We have some ink on it. It's pretty relatively large biopsy. And we look at low magnification, not inflammatory. There's something that's certainly clearly not inflammatory cells going on here in the dermis. Maybe a little bit of inflammation here, but not an inflammatory process. So probably a neoplasm here. And again, we're dealing with a punch, so we're sort of compromised our ability to evaluate breadth, symmetry, and circumscription. We're just looking at this. So we're going to have to use other features to help us define whether it's benign or malignant. Is it epithelial or non-epithelial? Well, it does look like spindle cell, so that favors epithelium. We're not sure what kind of epithelium yet, but we're going to go to higher magnification. Cells look kind of pink to me. They don't look the same color as the epidermis. So if it's epithelial, it's not going to be stratified squamous epithelium, maybe some kind of other type of epithelium, maybe adnexal epithelium, something along those lines. So we're going to higher magnification. And now we start to see these cells arranged in these little aggregations, and some of them are forming these kind of large, they're not really cords and strands because they're not just single cells, but they're forming these elongated aggregations here. They're almost forming nests in some areas. And they have this very, very characteristic pink cytoplasm. And so we're going to have to look at the cytology to see if we think that they're benign or malignant. There's really not any significant pleomorphism. The nuclei are pretty uniform. There's no mitoses. There's no real striking anaplasia or pleomorphic nature to these cells. And they have this granular pink cytoplasm to them, granular pink cytoplasm. So when you see that, and this is, some of these things like, you just have to kind of look at them, see them, registers in your brain, and you start saying, well, pink granular cytoplasm, think neural, think granular cell tumor. And this is an example of a granular cell lesion, granular cell neoplasm, which is a type of neural lesion. So the neural is an epithelial, it's neuroectodermal. So it is a type of epithelium. It's not, the classic type of epithelium I normally think about, but it is in the family of epithelial lesions. And this is just one of the neural neoplasms that we see in the skin. So basically, you have to recognize that this is granular cell morphology. Pink, they're little small granules within the cytoplasm. If you stain these, they're PAS positive, they're S100 protein positive. These are thought to be breakdown products, lysozymal breakdown products of the myelin. So they're in the Schwannian differentiation, but they're not really making myelin. They're not really classic Schwann cells. So this is what happens when you try to make myelin and you fail at it, and you get this granular morphology of the cells here. So this is a granular cell tumor, beautiful example of that. Now, just a couple of other teaching points about this. These are often seen on mucous membranes on the tongue. And they're also often seen in dark-skinned patients, in African-American patients. So I think they might show you a picture of someone that's an African-American individual with the tongue protruded, and you see this nodular aggregation on here, and then they show you a biopsy Cockerell and say the best diagnosis here is blank, and you should know right away that this is a granular cell tumor, because that's a classic setting where it occurs. It's often associated with overlying pseudocarcinomatous hyperplasia. We don't see that here. That can be a pitfall if you get a shaved biopsy and you don't actually see the granular cells beneath that. And I've seen that misdiagnosed as squamous cell a number of occasions. I've even made that misdiagnosis on occasion with a shaved biopsy. So something to remember. And then the last thing is that you can get granular cell metaplasia in certain lesions, granular cell fibrous papule, granular cell leiomyomas. There's a number of different settings where you can see granular cell morphology, granular cell atypical fibroxanthoma, interestingly enough. So you can get granular cell differentiation in certain lesions that are not granular cell tumors also. That's a little sophisticated. They're probably not going to ask you that on the board examination, but they very well could ask you about this entity because it's such a classic clinical presentation. Okay, the last lesion we'll talk about today again, we've got an enucleation biopsy here. So this was one that, again, like our mixed tumor of the skin we saw earlier, this might have been thought to be a cyst or something like that clinically, and this lesion is never diagnosed clinically. They usually present with a dermal papular nodule. The clinician thinks it's a cyst. They take a little incisional biopsy and they kind of shell it out, and that's kind of a classic story for adnexal tumors also. They don't really think that they're adnexal tumors. They think they're cysts, unless they've got some unusual morphology to them. So low magnification, probably benign, enucleated, pretty symmetrical. It's got some bluish cells in here, some cells that are pinkish. Is it epithelial? Well, it doesn't look like classic epithelium. Not really sure exactly what kind of differentiation is here at this power, but probably benign, and we're going to go to higher magnification, see if we can kind of tell. And as we do go to higher magnification, we can now see that it's got a spindle cell morphology here. So spindle cell, we think obviously non-epithelial. And the three classic spindle cell that you need to know for the board examination is fibrohistiocytic, smooth muscle, and neural. That's it. You don't need to know all the other spindle cell things that, the spindle cell soft tissue pathologists talk about for your board examination, which is good news. You just need to know those three. So you need to make sure that you can tell those three apart when you're looking at it. And so when we go to higher magnification, we say, well, if they're blunt-ended cigar-shaped type of nuclei with little periapical vacuoles, we start thinking about the possibility of a neural neoplasm. If you see areas where the cells look like they're kind of lazy fish swimming through the little water, you can kind of think of neural, like maybe some of these cells here, for example. And a lot of these are cutting cross-section here, so it's not obvious. But when you see these kind of nice little sinusoidal fish swimming in this sort of blue, this pinkish fibromucinous stroma, that's a nice classic example of a neural cell. If they're more jagged and irregular and stellate, you start thinking fibrohistiocytic. And then a couple of other things that help you is if you see these thick PAS positive linings around blood vessels in the lesion, that's pretty classic for neural differentiation. And then if you see these structures right here, where it looks like you get two little armies lining up to charge one another across this acellular area, these are Antoni A K bodies in an Antoni A Neurilemmoma, you've got the diagnosis here. And one other final teaching point about a Neurilemmoma is you'll often see the pre-existing nerve twig at the periphery that kind of led to the lesion. I don't really see it here, maybe here. Well, not really seeing it too well here. But basically the way these lesions develop is they kind of come off the outer part of the nerve twig and form a little nodule or a little bump off of the pre-existing nerve twig, where a neurofibroma is where it basically comes from within the nerve twig and it sort of explodes out. So this is a Neurilemmoma, schwannoma. This is making Schwann cells as opposed to the granular cell tumor, which didn't really make any myelin. Here you've got Schwann, myelin, and you've got the Varioliformis body. So this is an Antoni A type of Neurilemmoma or schwannoma. So that's it for today. So we got through all 10 of them. Hopefully that was educational for you. We've got a couple of conferences coming up. We've got a conference in January where you can go skiing and learn dermatopathology. And then, of course, in our summer, we've got our meeting as well. So have a great Thanksgiving, and we will see you guys next time. Hopefully you had enjoyed this lecture today. You're welcome to go back and listen to it again. It's all recorded. Take care.